I'd like to thank everyone for joining us here today for our last roundtable this afternoon titled Unequal Treatment, Confronting Maternal Mortality and Racial Disparities. As we come closer to the end of our event today, I hope everyone has gotten a chance to reflect on how interdisciplinary activism can be. As a cell biology and neuroscience major and an aspiring physician, I am taught to view medicine as an evidence-based practice. Through my women's and gender studies education, I have developed a critical lens with which to critique the norms and social practices in the world around us. And I strive to integrate these two perspectives into my activism. So what does the evidence tell us about the world around us? The facts tell us that Black women are 3 to 4 times more likely to die from pregnancy-related complications than white women. Even here in New Jersey, Black women are 5 times more likely to have a pregnancy-related death in comparison to white women. Day after day, pregnant people of color go into delivery rooms with a heightened risk of losing their life. The science makes clear that systemic discrimination is ingrained within our healthcare system. And to me, and to many of you sitting here in this room with us today, it can feel demoralizing, daunting, and even aggravating. But I'm sure that we can all agree that it is simply unacceptable to continue this way. While the fight is not easy, the persistent dedication of Dr. Pamela Brugge, Hannah Hamdi, and Dr. Damali Campbell to advocate for the elimination of health disparities gives me hope that there can be progress. I can't think of anyone better to moderate this conversation than Rutgers University's Gloria Steinem Endowed Chair in Media, Culture, and Feminist Studies, Dr. Roxane Gay. As a contributing writer at the New York Times, a professor, editor, and social commentator, Dr. Gay uses the power of words to make complex social issues accessible to us, and I can't wait to hear how she does the same as our moderator today. So please join me in welcoming Dr. Roxane Gay to introduce our roundtable today.
Thank you so much. And it's a real pleasure to be here today on this very brisk day. I mean, it's just brisk, but we will hopefully have a very enriching conversation about an issue that I think is important to everyone in this room. And so I wanted to introduce the panelists for our discussion. I'm going to ask them a few questions, and then we're going to open it up to the audience so that we can have a conversation together. So Dr. Pamela Brugge, MD, MS, is a board-certified obstetrician gynecologist in New Jersey and is affiliated with Hackensack Meridian Health Raritan Bay Medical Center. She received her medical degree from Rutgers Robert Wood Johnson Medical School and has been in practice for more than 30 years. Dr. Brugge is on the faculty of Rutgers University Robert Wood Johnson Medical School in the Department of Obstetrics, Gynecology, and Reproductive Sciences. She also serves as a faculty in the Division for Advocacy and Outreach at the Rutgers, that long name, Women's Health Institute. She has received several awards throughout her career. Her interest in disparities in healthcare has led her to address Black maternal infant morbidity and mortality, especially in New Jersey. Dr. Brugge, a graduate of Douglas College, Rutgers University, is the founder and the president of the New Jersey Black Women's Physicians Association. And my phone is going crazy, and I know that it's my mother. I know, right? Like, Hannah Hamdi is a birth doula and women's health advocate and researcher, and formerly a clinical data analyst at Planned Parenthood. While at Rutgers University Douglas College, Hannah was part of the engineering school and majored in biomedical engineering with a minor in women's and gender studies. After completing her degree, she received her master's in public health from Columbia, focusing on epidemiology and earning a certificate in forced migration and health. She has worked primarily on research studies and needs assessments in many different contexts, such as child-friendly spaces programs, evaluation for Syrian refugees living in Jordan, a needs assessment of palliative care in hospitals in Senegal, surveillance of childhood asthma in New York City, and an evaluation of a health workforce strengthening program with IntraHealth International in Uganda. Hannah is extremely passionate about working with marginalized communities and wants to raise the value of women in the world. And last but certainly not least, Dr. Damali Campbell Oparaji is an associate professor in the Department of Obstetrics, Gynecology, and Reproductive Health here at the Rutgers Medical School. We're not going to say that name over again. In Newark, New Jersey. She acquired her ABAM certification in addiction medicine in 2014, and along with other colleagues and staff, helped to establish Healthy Beginnings, a dedicated clinic session for women with tobacco, alcohol, and substance use disorders. Dr. Campbell has found synchrony in her work advocating for improving breastfeeding support, reducing health disparities, the expansion of group prenatal care and treatment of substance use disorder in urban communities, and in particular with women of color and other underserved populations. Dr. Campbell has training and experience working in urban areas, having undergone primary medical education in North Philadelphia at Temple University School of Medicine and residency training in Jersey City, New Jersey. She is currently the president of the New Jersey Medical Association, the State Society of the National Medical Association, a board member for Planned Parenthood for Metropolitan Northern New Jersey, and on the Fundraising Committee for Partnership for Maternal and Child Health of Northern New Jersey. Dr. Campbell sees her work in the area of addiction medicine and obstetrics as a place where she can work with women in meeting goals regarding pregnancy and parenting, which can change the trajectory of many lives. So thank you for joining us here today at Rutgers. Now, I know that throughout today you've heard speakers and panelists who have shared information about the legal and the political implications of a post-Roe world for women, and it's something that we're just beginning to grapple with and will continue to grapple with, unfortunately, for many years to come. As healthcare providers, what can you say about the health repercussions that people are going to face, and have we started seeing those repercussions already?
I believe we have not started seeing the health repercussions yet. And a few things that I just wanted to leave you with, and I know that we were talking about trying to be positive, but I do want us to be positive, but I want each one of us to leave with thinking about some kind of action that we can take. So maternal mortality is going in the wrong direction. And really, maternal mortality is just a reflection of overall poor health of women in our country. I'm going to say that again. It's a reflection of the overall poor health of women in our country. Abortion, legal abortion in the United States is safer than childbirth. Do I need to say that one again too? Okay. So legal abortion in the United States is safer than childbirth, and the rates of complications are low. So when we talk about limiting women's access to health care in the form of limiting access to reproductive choice, we're automatically saying that we want to further increase the high maternal mortality rates that we already have. I'll stop there.
I think that's something for us to chew on already. Yes, I would love to hear from other panelists.
No, I actually just wanted to piggyback off of what you said, Doctor. And unsafe abortion is one of the leading causes of maternal mortality. It is also one of the preventable causes of maternal mortality. And so I think depending on the way you look at it, it can be like, oh, if we work on making access to abortion legal and safe for people, we can prevent a lot of maternal deaths.
I think we have to understand that abortion care is medical care. It is not, it has become politicized, wrongly so, because it is part of women's health care. Along with abortion rights, we have to remember that there's also been an interruption in contraception also. So now we know that already a large percentage of our pregnancies are unintended in the United States because of our jacked up, discoordinated healthcare system that we have. Education, yes, that we also, we can't even go to a Board of Ed meeting, then you'll understand. But we just have that problem already with contraception, limiting it, increasing unintended pregnancy, fighting against abortion, and it just creates what actually has been said you increasing the risk of maternal mortality. And there are so many cases, medical cases, if we just go into that abortion is the management. It's a management option. And we've just taken that away for many, many people.
Equity certainly plays a large part in this, and there are significant health disparities among women. We are not all created equal, unfortunately, particularly when it comes to health. And there are reports from the CDC that say that non-Hispanic Black women have a 2.9 time higher rate of maternal mortality than non-Hispanic white women. Are there other disparities that we're seeing in maternal health care that are disproportionately targeting women of color? And secondly, we talk about this a lot, at least in certain circles, about especially Black maternal health. And we talk and we talk and we talk, and it seems like that's all we do. What are some of the things that we can do to address this in ways that are sustainable?
So, not only is Black maternal mortality high in the United States, but it's extremely high in New Jersey. New Jersey is the 47th state in the nation, while we are in the top 10 richest state in the nation. And that's largely because the Black maternal mortality rate is basically now 7 times, and we probably predict that it will go higher because we're not out of COVID, but we've had a long, several years of COVID where we know that the maternal mortality was related highest for Spanish-speaking and then for Black pregnant persons. So we know that exists. But we always have to say, this is across socioeconomic class. Mm-hmm. So it's not just our medical care that needs to be addressed, but there are other issues that needs to be addressed. And the most pertinent in this country is systemic racism. And if we do not address systemic racism, we will not get past a lot of our health disparities, not just found in obstetrics. So we see that, and most people know the story of Serena Williams, right? But she's one out of so many women that are impacted because of racism. They are not believed, they are not heard, they're not listened to, they're discounted. And so when their symptomatology gets so bad that either they go into the ICU, or the infection is to the point that it is septicemia, or they bleed so much that we can't bring them back. That's when the death occurs. Or worse, we have enough of the women that have high morbidities, right? So they have complications that actually result in them being in the ICU. Long-term effects because of things that could have been prevented if they were heard, they were listened to and believed. So I think the main thing is that we have to address racism. That's one of the things that I feel that we need to address, and it needs to be addressed, in the educational system, but everyone in this country has a responsibility to actually address this and not be a silent bystander and learn. There's enough information out there that gives you information about how can you be an advocate.
And if I may just piggyback, so just to go back to that national statistic that Black women are 2 to 3 times more likely have a higher maternal mortality rate. And in New Jersey, Black women have a 7 times higher maternal mortality rate. And it's easy for us to live in New Jersey and feel, we're progressive, we're next to New York, we have a great governor. We do have a great governor. But I just want to lay this on you. 33% of New Jersey counties did not have an abortion provider. New Jersey. So we don't have to go far. I mean, it's easy for us to empathize with those states, right? But we don't have to go far. Let's look in our own state and talk about the folks who don't have. And as people are taking a plane from Texas to New Jersey, who are they pushing out of the way? They are pushing out people who are poor, who don't have the cash, who are people of color, who are immigrants, who would like to have some of these services. So we have to protect these rights for everybody, for every state, but we can't become complacent and think that because we have it here in New Jersey that everybody has access to it in New Jersey, because then we're fooling ourselves.
What accounts for that disparity, that there are 33% of the counties in New Jersey without an abortion provider? Is it that there aren't enough people learning in medical school?
So that's a great question. Well, first of all, New Jersey has a problem because we are training quite a number of providers, but about 30% of providers leave our state because it's a very expensive state to live and practice in. So that's one problem. And then as far as, right now within the specialty of OBGYN, there is a fellowship in what we call complex family planning. So there are folks who are training to provide services to people all over the country, but now they're facing a conundrum because they have now spent time and energy to learn how to provide these services, and they were thinking they were going to go back to North Carolina or Texas or their home states to provide services, but now they can't. So now they've invested time and energy to learn these skills, and now they're faced in a situation where they're going to go to practice. They can't all just come. We don't have enough jobs, places for them to just come and practice this one particular skill in New Jersey and New York. But furthermore, like I said, the issue in New Jersey and New York is it's very expensive to live.
I kind of wanted also to touch on expensive to practice. OBGYNs have the highest malpractice that they have to pay over any specialty. And that makes it like kind of prohibitive in a sense. And I don't know if that varies by state, but it does? Okay. Yeah. And then, I was also going to add the class piece is really important when we talk about abortion care, because it's, I think Ruth Bader Ginsburg once said, it's like when she passed, did she pass Roe v. Wade? I don't know. But when the Roe v. No, she didn't. When the Roe v. Wade decision came out, she said that abortion care is not about the people who are wealthy because they will always have access. And this is translated to a lot of different services. Wealthy people will have access to things that poor people will not. And so when we make something a right and we protect it and legalize it, it's for the people who will have limited access, right? And so, I think that's really critical when we talk about maternal health care in general and when we talk about abortion care in particular.
Dr. Brug, you said that class and wealth is not necessarily something that helps Black women when it comes to pregnancy. And I've interviewed a lot of Black women, a lot of very well-known Black women for my podcast, and every single woman I've interviewed has lost a child in childbirth or through late-term miscarriage and things like that. And I started to notice this after several conversations, and I just thought, how is this possible that this many Black women are losing children in this way? And so is there any hope? I don't tend to traffic in hope, but is there any hope when, I just don't, because as you said, the solution is to deal with racism. So, that kind of means we better not get pregnant. How do we begin to address a problem when you can't even buy your way out of it?
It is so complex. But one of the things that we can look at are putting services, support systems around Black pregnant persons, regardless of their economic status, such as doulas, right? Because they can be your support, they can be your voice. But there are other things that are needed, right? Because if we look at preterm deliveries, right? And this is one of the most common reasons that there are neonatal deaths, is that there is seen what we call weathering. So this is a process basically where the impact of your life and the stresses in your life can actually impact your pregnancy. So the simplest things is the hormones that actually cause, that rise during stress are also the ones that kind of are involved in the initiation of labor. And so if you look at preterm delivery rate, it is much higher for a Black pregnant person than a white pregnant person. And depending on where you are, it's like 3 times. And then you look at, so people are like, oh, well, that could be, something to do with the race, like being Black, right? You take immigrant Black pregnant person, they come into the United States, their rate of preterm deliveries are basically the same as a white pregnant person. Now, let's go to the next generation, and you see that it starts to climb. And by the second generation, they are just like us in the United States. Yeah, and their rate it just climbs and becomes just like African Americans that are in the United States. So that tells you that it is not something to do with being Black, right? It has to do underlying causes, and one of the things has to do with the stress, and the main stress is racism, microaggressions, etc. I know I'm being a downer.
Oh, no. You know what? You're being honest.
But we can mitigate that, right? We can mitigate that through education. I think education of providers. We can mitigate that through education of women. Unfortunately, we talk about the social determinants of health, which are extremely important, but a lot of professional Black women, they think, well, I don't have those social determinants of health, so they think I'm out of the water, right? So we need to educate them that they are still at risk because of toxic stress, right? And then we need to, we need to educate women, we need to educate providers, so that all providers, we have great data that shows that providers that do understand cultural backgrounds can provide better care, but it's not realistic when the population is 15% African American and less than 5% of physicians are African American. So everybody's not gonna get an African American physician, right? But we have ally physicians, so we can educate them about systemic racism and implicit bias so that they can provide better care to patients.
Are there, what did you want to say, Hannah?
I wanted to add something about weathering. And I think you probably touched on this, but it really it impacts many communities, and I think it also, it impacts not just maternal mortality, right? It impacts lots of different health outcomes, which is unfortunate. Sorry, I'm not helping with the hopeful either. But, and it's actually interesting because when the weathering hypothesis came out, they looked at a study of mothers who had children over different times in their life. Yes. And Black women who had children earlier had better health outcomes than Black women who had children later. And that's kind of how the hypothesis came about, which I thought was also interesting and maybe a little bit of hope, I don't know.
Yeah,
not really.
There is, can I just say that actually I have students working with me trying to address this whole issue of trying to find what we consider like-minded physicians. So what we are doing is a study to kind of figure out, well, what are people looking for in their doctor? What are those characteristics? And then can we develop a tool that actually will identify those physicians who are then what we consider culturally humble. That means you take cultural competency and you actually use it. And within there is a racial competency part. And so that's what they are working. They've been working on this for a year. And most of them are Douglas students, in fact. So, hey, kudos.
Are there any initiatives, either at the medical school level or at the community level, to begin to find people who are willing to learn, especially medical professionals, and not just the doctors, but nurses, midwives, doulas, who are willing to learn about the realities of racism and how it affects maternal health?
I mean, I think that many organizations are starting to hear that, and kind of one of the things that we want to just push back against is just people not in their organizations not just saying, take an implicit bias course and check the box, right? It's obviously more than that. Everybody has like this DEI officer, right? But what does that really mean? So, I mean, we know that there's efforts out there, but we want them to be meaningful and sustainable, and really make a difference in the work that we're doing.
Yes.
I just wanted to add that I trained as a doula, and I trained with an organization that focuses on Black and low-income mothers, so they really center those experiences in their training. And I think that kind of like community work and like grassroots work to reach those mothers and to also support them like free of charge is really important, and it is being done. The organization I worked with is called Ancient Song Doula Services. They're based in New York and also in New Jersey. And I'm sure Sister Song in Atlanta has done something similar.
Mm-hmm. Yes, they have. And it's an ongoing thing. And what's interesting is that there are these initiatives, but they're happening at the nonprofit level and at a very small scale, while this is a very large scale problem. You know, we have talked about a lot of really challenging issues, and is there a way forward to things improving? And do you envision that in our lifetimes?
I'm old, so I don't know.
You know what? Real.
I pray, but really seriously, because I think there is a way moving forward, and I am very hopeful that the generations behind me are keeping us accountable. And there are very organizations that are demanding that change does occur. And I think it's also helpful that we are we're having a seat at certain tables that we may not have had before. And I'm hoping that makes also a difference. I'm hoping also that the surge for voting increases amongst young people, because I think that's where we have to get political power to kind of make these changes. And the only way to get political power is to vote. And so that's what, kind of keeping me set that there's hope.
I feel like it has to change, because if it stays like this, it's going to keep being a mess. Like, it's already a mess, and it's getting like a worse mess. And I think it's imperative that we work to change this. And I think what that work is can depend on who we are, what we do, what our skill sets are, but I feel like we all have to find what that looks like for us.
Yeah, I too must remain hopeful because I have a daughter, and enough said, right? I have a daughter, right, who just turned 18 a couple days ago. And so I realized I was at a Hill Day, a preparation for a Hill Day, and one of the people said, do you realize certain percentage of 18-year-olds haven't been registered to vote? So I immediately text my daughter, have you registered to vote yet? I mean, she's like 7 days after turning 18. And she said, not yet, because I was trying to figure out, should I vote where I'm gonna go to college, or should I vote? No, just register to vote. Now, register right now. So, I hope everybody in this room is registered to vote. And, the other piece of that is accountability, because you young people have to hold these folks that we're electing to office accountable. If they say they're going to support something, they're going to do something, we have to hold them accountable. And we're living in this digital age, so I feel like, everybody wants to have this immediate result, and we're not that great at delayed gratification. So we have to work on that a little bit. And one of the things, again, I want us to think about action items. So one of my action items is that I'm gonna start registering each one of my patients to vote. Like, I'm gonna be intentionally asking them are they registered to vote, and making sure they're registered to vote, because a lot of times the patients that I serve, right, they don't think that anybody cares about their opinion. They don't think it matters, right? But we have to make them know that it does matter.
I agree, and I think that's a great idea right there on the patient level.
My question builds right on Hannah's, and I wonder if you could talk a little more about midwives and doulas, and if you think they are making an intervention in Black maternal mortality, and who has access to doulas and midwives.
I think the kind of unfortunate reality is that doulas and midwives are available to people who have like a certain tier of health insurance or can afford to go cash only or something like that. And I think there is a lot of work because of there's a lot of research done on the maternal improvements from having a doula, that there are a lot of community-driven efforts to create doula support for lower-income women of color in particular, like Ancient Song, like Sister Song, and others. But I think because the United States doesn't have a midwifery model of care, midwifery is a thing of privilege, typically. And I think that doesn't help our already bad maternal mortality rate. Like, a lot of countries that have a midwifery model of care definitely fare better, but they also have like typically national healthcare systems and other things that support that. Thank you for your question.
So I think, kind of the one thing I would say is we should, we oftentimes say doulas and midwives in the same breath. And from my midwife folks, they would say to me, midwives are clinicians, right? So a midwife is a trained professional, a trained birth professional, and doulas are not medically trained, but they are support people. And oftentimes they're found in similar settings, but they have different roles. So a patient could have a midwife and may or may not have a doula. A patient could have a doctor and may or may not have a doula. So I just want to be careful that we don't interchange those terms, because a midwife is a trained medical birth professional. There are a lot of strides in New Jersey to increase the midwifery workforce, because there are many models that show that midwifery care is helpful to reduce maternal mortality. Money has a lot to do with why, doctors have gotten involved in birth, and I won't go into the history of birth, but there's a whole thing. And if I don't have any money into it, but if you watch Call the Midwife, that series on Netflix, it's fascinating, and it really just brings a lot of humanity to birth, and I believe that was present in the United States for a long time, but when money got involved and anesthesia and insurance, it became a different story. So just want to separate that. Patients can have a doctor or a midwife. They can have a doctor and a midwife, but they can also have a doula. But the doula is a support person that is also, everybody has their role, right? And a lot of times the doulas that we work with in Newark, they not only have their role in labor, but we also have some postpartum doulas. So some of them only do postpartum care. They help mom postpartum with breastfeeding and support. Extremely useful when we're thinking about what happens after birth, right? Because women need a lot of support after they give birth.
Thank you so much for being here. I wonder if you can talk about data collection in New Jersey, because we were I'm sure many people know that the maternal mortality report in Texas was delayed last year. The biennial report was supposed to be released before the midterm election. It was delayed, and it was finally released in January. And a lot of people say that the report actually reflects data from 2019, and that even though that data is incredibly important, it is useless in a way to have it in 2023. So how does it work in New Jersey? What are some of the challenges when it comes to data collection? And with the overturning of Roe v. Wade, what do you expect will happen with those rates going forward?
Yeah, I can answer a little bit of that question. Part of my role is as the chair of the Maternal Mortality Review Committee in New Jersey. So what happens with data collection is that we review every death that occurs in the state of New Jersey. And in New Jersey, just like in the United States, we define a maternal death as a death that occurs up to 365 days after the pregnancy. So you can imagine that what that means is if somebody dies on January 1st of 2023, or if somebody gives birth on January 1st, 2023, we now have to wait a full year, right, in order to see if they survive the year. So it does take an inordinate amount of time, more time than any of us would like, right? And then there is the data abstraction piece, right? So there we have data, we have nurse abstractors that have to review. And we would think that with electronic medical records, that process is easy. That process is hard. And sometimes our nurse abstractors are reviewing thousands of pages of electronic medical records. And so the process does take a long time. So our goal for the CDC in the state of New Jersey, well, it's with the CDC in general, is to be on a timeline of 2 years. So for most people, that doesn't feel right, because it means that by the time you get the data out, it's 2 years old. But what I can tell you is, unfortunately, the causes of death haven't changed. So we can keep looking for some new data, but the causes of death haven't changed. Cardiovascular disease. When we look at pregnancy-related deaths, the deaths within the first 42 days. Hypertension, cardiovascular disease. So yes, I agree. We want more recent data, but we can get data from 2016, 2017, 2019. It's not gonna be different from 2021. It's still cardiovascular disease. It's still hypertension. It's still preeclampsia. And when we look for the 365 days, so what we call pregnancy-associated deaths, suicide, and substance use disorders. It hasn't changed. So I agree, we want more recent data, but I don't know why we want more recent data. The causes haven't changed.
Well, thank you so much. We have run out of time, but I wanted to thank these amazing panelists. Dr. Pamela Brugge, Hannah Hamdi, and Dr. Damali Campbell. Thank you guys so much for keeping us informed about the stark realities and reminding us that we have a civic responsibility to vote and to educate ourselves and to also, as this woman here suggested, educate our children. And so thank you everyone for joining us for this panel.